Well, we have enough uh, time here to enjoy some time together and share some great cases. I'm very pleased that I've been finally able to arrange a time for my wonderful colleague, Dr. JoElle Peterson, to share some of her expertise and experience. She is a very much sought after teacher in our institution, both by the residents and the medical students, has won a number of teaching awards, and it's just a wonderful person to be around. In addition to neuropathology, she also does head and neck pathology, some thoracic pathology, so she's a very well-rounded an experienced pathologist who is always a great person to learn from. And I'm sure that you will enjoy listening to her today. So, JoElle, with that, I'll turn the stage over to you, and I'm going to darken my screen so that you can have the full screen.
Well, thank you, Dr. Hossel. I would be remiss if I didn't mention the fact that Dr. Hossel makes everyone better just by being around him and knowing him. So he's so kind, but honestly, I aspire to be more like him. I'm going to put in the chat a link to the DAPA presentation. There are some polls, some questions on some of these slides that if you are able to access this and would like to answer those polls as we're going through this in real time, I encourage you to do so. But if not, you can watch it on the screen, as I will share my screen in just a moment. I always like to start off with sort of what the scope is for today. So not really having a particular topic in mind, but just general neuropathology. The approach that I have taken is sort of a broad overview of many of the entities that I see on a regular basis, but not necessarily a very deep dive. If you are at all familiar with the WHOs, you know that in the last 10 or 15 years, we have had three different iterations of diagnostic classifications of tumors in the brain. And that can make it difficult to create a teaching session that actually has longevity, meaning that if I were to teach you exactly what all the diagnostic criteria are for WHO right now, in a few years, if they change it again, it will be irrelevant. So my goal is to point out areas where you need to know and check the current classification, and we'll talk about some of those things as we get to them. But also, I find that the more that we depend on molecular diagnostics, and I include myself in this, but the more that we depend on molecular diagnostics, the the less good I feel like we are at histology and diagnosing things by histology, because, I find myself sometimes looking at something and going, well, I think it might be this or this, but I have to do molecular anyway. Instead of saying, no, force yourself to figure this out, without relying on that. So with that, we'll get started. And let me see. Okay, I have to share my screen. And I also encourage you, if you have questions, please go ahead and put them in the chat when you have them. I always prefer to be interrupted if something I'm saying is unclear in the moment than to come back to the end. So, right, just to confirm, are you able to see my screen, my slides? Yes, okay. And I'm going to move that over here. Okay, so this is a dura-based mass. So I'm going to give you a little bit of a hint here. Dura-based mass of a let's say 60-year-old woman, the right frontal convexity. And we see sort of this swirling, whirling pattern with what we would consider to be syncytial cells, meaning you don't really see their cell borders. They all kind of run together. And moderate amounts of cytoplasm. And really not any high-grade features, no mitotic activity, no necrosis. Well, actually, there may be a little mitosis in there. I'm not 100% sure. No necrosis. So this is a pretty straightforward, easy. We start off with the easy stuff. What is the diagnosis? I'll look and see what the results are. So we have one vote. Our options are Schwannoma, Meningioma, solitary fibrous tumor / HPC, Angioparasitoma, and Ependymoma. So one of the first points that I like to always make when it comes to neuropathology is that the imaging is of utmost importance. I don't ever sign out a neuropathology case without having either reviewed the case, the imaging myself. If it's an MRI, I feel comfortable doing that. If it's anything other than MRI, I read the radiology report and I let them tell me their findings. But the imaging is key. And so with a dural-based mass, excuse me, we can pretty much exclude one of these, and that is ependymoma. Now, never say never. You can see weird things sometimes, but for the most part, dural-based mass is not going to be ependymoma. This is going to be a ventricular mass or connected close to the ventricle. So that leaves us with these other three. Schwannoma is also not a dural-based mass. A schwannoma is a nerve-based mass, although again, there are rare reports of unusual locations for schwannomas. But we're kind of left in general broad categories with meningioma and SFT. So looking at the poll again, we have a couple of votes for meningioma and one for schwannoma. And yes, of course, this one is a meningioma. So meningiomas on low power, their variability, the cellularity is really highly variable. Sometimes they range from super purple to other times, excuse me, I'm going to make sure, yeah, there we go. Other times on low power, they're going to be very pink. And so you don't always really have a sense from low power what they're going to be. But in general, nuclei round to oval, syncytial cells, and you may get some swirling, I believe. Let's see, yeah. We kind of get a sense of swirling right here, the whorls. And if you get those on a squash prep at frozen section, that can be really helpful. So this is a meningioma. Now that brings us to this image, and that is to, again, remind you that imaging is of utmost importance. We can really kind of focus in our diagnostic categories based off of the imaging. Again, sometimes you'll find, though, that you've got something weird that doesn't fit into the classic picture. And in those cases, you need to think outside the box after you've excluded the more common things. But meningiomas in general are going to be dura-based. Often they're going to be mass forming like this one, but they can be on plaque, what we call plaque-like, and growing more in a linear fashion. But importantly, meningiomas tend to push the brain away and not invade so much. Now, we're going to come back to this in a moment because I know that if you have any experience looking at MRIs, this one would concern you as it does me, but we will come back to that in just a moment. So this brings us to my next image, and that is one that looks like this. Now, if you were to take the American Board of Pathology board exam, you might get a picture that looks just like this, only what's inside the box, and then they'd ask you the diagnosis. And this would cause panic for me, right? Because I'm going, I don't know, it just looks like sclerosis. And the key is that there are some variants of meningioma that don't look a whole lot like the picture I just showed you. But if you look around, you're going to find areas that have still the meningothelial cells, the round to oval, the swirling, the syncytial appearance. And so the diagnosis of meningioma can sometimes be a little bit challenging if you have one that's a little bit unusual. But I encourage you to go back to the imaging, again, dura-based nodule, avidly enhancing dura-based nodule that pushes the brain away. And then again, look for these arachnoid type cells in areas anywhere on your slide, because sometimes they can be not so frequent, but generally for the most part, they're going to be present. Now, here is another example of a meningioma, but this one's a little bit different. And in this one, we're seeing what kind of look like vacuoles maybe, or cystic, microcystic spaces containing material. And so this is one of the unique variants of meningioma that has a little bit of a clinical implication, and which will take us back to that imaging finding. But before we get there, I want to ask you, what antibody will be positive in these secretions? GFAP, brachyury, STAT6, or CEA? If you're not sure, just take a guess. What antibody is positive in the secretions of a secretory meningioma? Okay, we have a guess for CEA, and that is the correct answer. Now, I will tell you that I always considered that to be just sort of like a, oh, gee whiz, textbook information. You're never going to use that. And I actually never did until about 3 months ago. And I've been in practice for over 10 years. I've seen lots of meningiomas, and I've never performed a CEA until about 10 months ago, or excuse me, 2 months ago. And the reason I did it was because the imaging, excuse me, I'll show you. This is an example of a CEA antibody highlighting those secretions. Okay, so the reason I did a CEA in that case is because the imaging looked an awful lot like this. And so this is the important point, is that when a patient has a massive amount of edema, and that's what this hypointensity is here on this imaging, this darkness, when the patient has a massive amount of edema in association with a meningioma, that tells you it's very likely going to be one of two things. Number one, it's either going to be a brain invasive. The meningioma is invading the brain and causing irritation to the brain tissue itself, resulting in this massive amount of edema, or it's probably going to be a secretory meningioma. So the secretions in the tumor itself are irritating to the brain and result in a tissue response, which is basically vasogenic edema. So anytime I see edema in an imaging, preoperative imaging, or the radiologist describes edema, especially if it is an amount that is really out of proportion to the size of the tumor. So if this is a non-invasive meningioma, there should be absolutely no tissue response. There should be no edema here at all. The brain, you see meningiomas like this all the time, and the brain doesn't care. It just doesn't even recognize that it's there. So when you see something that's this size and you've got this massive amount of edema, that should cause you to think, is this a secretory meningioma or is this invasive? So when I had that case and I see these things that are inside these little micro cysts, and I couldn't decide, is this secretory or not? The implication was that if it's not secretory, it's potentially brain invasive, which I'll show you in a moment actually affects the grade of the tumor. So, but I didn't see any brain invasion on the specimens on the tissue pieces that I had. So I performed the CEA. The CEA was in fact negative, which indicated that I needed to go back and submit the entire specimen to make sure that I'm not missing brain invasion. And so this is one that is of clinical importance, because if it is a secretory and it's causing this edema, if they've removed it, it's going to be a grade 1 for the most part, assuming it doesn't have any other high-grade features, and they just need to be followed and they're fine. However, if it is not secretory and it is in fact brain invasion that's causing the edema, that's important for the clinical team to know. They need to follow this one a little bit closer and watch for recurrence and or disease progression, higher grade. So prior to the most recent WHO, this was the grading mechanism scheme for meningiomas. You have the 13 different histologic subtypes, 9 of which were in grade 1. 2 were in grade 2, clear chordoid and clear cell, and then 2 of them were in grade 3, papillary and rhabdoid. And this was the reason these were over here, papillary and rhabdoid, is because there were studies that showed that the ones that had that diagnosis tended to have a worse outcome. However, those studies also showed that those tumors also had other high-grade features. They didn't just have rhabdoid morphology or papillary morphology. They also had lots of mitotic figures and or other high-grade findings. And so this has changed now, such that the most recent WHO is putting papillary and rhabdoid back over here in grade 1, such that this is the final, so the current final grading scheme. And that is that we have 11 in the grade 1, and forgive me, I noticed an error here. I should have pulled this down here. But the current grading scheme is that we're going to take all 11 of these, evaluate for high-grade features such as brain invasion, 4 to 19 mitotic figures, or 3 of 5 of the high-grade features, noting that necrosis only counts if they haven't performed preoperative embolization. This used to be a pretty frequent thing in my institution, but in the last about 5 years, I'm finding that they're not doing this much anymore. I'm guessing because there were some unintended consequences from the embolization, since you can't really control where that goes. But 3 of 5 high-grade features can also count, or if you have 20 or more mitotic figures in any of these grade 1 histologies, you can become a grade 3. Now, it's important to note that if a grade 1 becomes a grade 2, its name becomes atypical meningioma, and if it becomes a grade 3, the name becomes anaplastic meningioma. We drop the histologic name. Chordoid and clear cell still remain, though, as grade 2s according to their histology. It's not required that you find any of these features present to give them a grade 2. So a couple of additional things to note. This grading scheme, I mean, it's what we have right now, but there is a disconnect in some cases. There are some patients who may have a grade 1 tumor histologically and according to the WHO, but clinically don't behave that way. They behave in a more aggressive manner. And this has really been connected to their molecular signature. So in our institution, we are able to send every tumor that we receive for molecular testing. And so we are able to evaluate for these. I recognize though that there are going to be many places where molecular testing is not available in that kind of way. Like, you can't just send every meningioma for molecular. So a couple of things that you may consider is number one, any tumor that is a grade 1 that meets grade 1 criteria according to the WHO, but maybe has some other findings that are concerning. For example, I had one of these last week. I had a meningioma. It didn't have mitotic activity. It only had one of the high-grade features. It had a little bit of necrosis. So it didn't meet this, and there wasn't any brain invasion. So it didn't meet grade 2. However, the Ki-67 was 15%. That's just way too high for a grade 1. So I'm very much suspecting that this one is going to fall into that category of not behaving like a grade 1, according to what the WHO would predict. And so in that case, I add a comment that says that this meets WHO criteria for this, but has other concerning findings. And of course, we're sending for molecular, so they'll be looking for some of the more high-grade molecular findings and following up on that. But there are other ways to sometimes kind of predict behavior if you really pay attention to some of these findings and document them when they're there. And that can be helpful for the clinical team. The other thing is rhabdoid, for example, the rhabdoid morphology, loss of BAP1, if you have the BAP1 antibody, that can be an indicator in a rhabdoid tumor of more aggressive behavior. So that one may be a little bit easier to evaluate if you don't have molecular readily available. And so here's an example of a rhabdoid tumor. Now, the rhabdoid morphology, there are a lot of times that I'll look at meningiomas and I'll go, oh, wait, I think that's rhabdoid. I really limit that diagnosis to ones that look more like this. Not every cell here looks like it has that, eccentrically located nucleus. Many of them do, but it's not every single cell. But the other feature that I'm looking for is prominent cell borders. That's something that I see a lot in rhabdoid meningiomas, and that is a little bit distinct from the more syncytial appearance of the more traditional other types of meningioma. So that might also be a feature. And again, a BAP1 stain here may be helpful if you have that and aren't able to do the molecular testing. Okay, so this brings us to the next tumor. And let me see what okay. So we'll zoom around. We'll start here, but let's zoom around a little bit. On again. Okay, so this is pretty much a spindle cell tumor. This area may remind you of some things you might have seen before. Not a lot of mitotic activity, necrosis. There was something that I found that I think I just passed. Let me see if I can jump. Yeah, here we go. It's a little bit of vascular sclerosis. There may even be something that mimics vascular proliferation. Looks a little bit like that. And then areas that are a little bit pleomorphic here. Okay, so spindle cell tumor. I haven't given you a location, but random nuclear pleomorphism, vascular sclerosis, and some variability in cellularity. I kind of skipped through that quickly, but here's an example of that. A little less cellular, a little more cellular, some things that look a little palisading. So what is the diagnosis? Options: SFT, ependymoma, malignant peripheral nerve sheath tumor, or Schwannoma. Excellent, Schwannoma, yeah. So most often in the CP angle, generally this is not a diagnostic challenge, but the times that I find these to be a little bit, I'm waffling a little bit, is often at frozen. And then I have to remind myself, we don't have to have a final diagnosis at frozen. So I might say something like spindle cell tumor, Faber, Schwannoma. I made that diagnosis yesterday, actually. So good, this is a Schwannoma. And then just for sort of a board review, bilateral vestibular lesions of this tumor are associated with which gene mutation? Very good, NF2. The acronym I use to remember this is called, MISME, M-I-S-M-E, so multiple intracranial schwannomas. also known as bilateral schwannomas. And then the M is meningioma and E is ependymoma. So for NF2, multiple intracranial schwannomas, meningioma, ependymoma are the hallmarks of an NF2. Okay, so that one was pretty straightforward. Let's see. There we go. All right. Now we're shifting gears again. And so I will show you, zoom in here. We have some apoptosis. This would probably be described as a small round blue cell tumor. Look at another piece. So this is the basic morphology that we're seeing. You may get some hints at, possible little rosettes, maybe. Those also could just be little vessels. All right, so based on the histology, what is the diagnosis? Options are ependymoma, medulloblastoma, meningioma, ATRT, or cannot be determined. Ooh, no votes yet. Okay. Give it a second. We can keep looking around. Maybe a little hemorrhage. Have any guesses? We have a medulloblastoma and it cannot be determined. Okay, so this is a bit of a trick question, but the illustrative trick question, hopefully. So yes, the answer is cannot be determined because small round blue cell tumors can occur anywhere in the central nervous system, and their name is very much their name is very much determined by their location. So if I give you a context, a history of this is a 2-year-old child with a posterior fossa mass, then absolutely medulloblastoma is at the top of the differential. However, we wouldn't still be able to remove atypical teratoid rhabdoid tumor from that differential and would still need to do additional testing to be able to make the diagnosis because ATRTs can at times look identical to medulloblastomas and you wouldn't necessarily know that just by looking at it that it's not a medullo. So in general, especially in a young child, I don't ever sign out a medullo without doing the stain that helps us to distinguish it from ATRT, and that is the INI1, also known as BAF47, also known as SMARCB1. So ATRTs, the vast majority of them, are going to have loss of INI1 due to the presence of a SMARCB1 mutation. So there's some other molecular findings associated with ATRTs that you should look into, but in general, medullo can be usually distinguished from ATRT based off of immunohistochemistry. Now, the next question, which of the genetic findings below are associated with a good prognosis? And yes, excellent, Wnt activated. So that brings us to the subgroups. Now, this is a lot of information, and I find that this is where obviously molecular it can be very, very helpful. Although there are ways to come at this with immunohistochemistry, but I would encourage you to go reference that in the WHO just because it really depends on what antibodies you have available and morphology. But this is from the 2012, actually, a 2012 publication that defined them by 4 different categories. So there was the Wnt altered, the sonic hedgehog altered, group 3 and group 4, and these were group 3 and group 4 because we didn't have a common alteration to give them that name. Now these can also be somewhat predicted at by morphology, specifically the desmoplastic nodular and the classic appearance are frequent in sonic hedgehog, but if you see the nodular or desmoplastic appearance, really sonic hedgehog is going to be the most likely. And so paying attention to the histology is important here. But for the rest of them, it really kind of needs additional evaluation. Since this was published, so in the last 12 years, these have now been subdivided even further. So Wnt has stayed the same. Sonic hedgehog has now been divided into 4 subgroups. Groups 3 and 4 have been subdivided into 8 subgroups. Here's a picture from the latest WHO showing groups 3 and 4 and their subgroups and their overlap, and their histology pattern that can be seen. So this is well beyond, I can't go too deep into this, but the reason why this is important, again, is because some of these actually have a pretty good prognosis, despite the fact that medullos together collectively, we still call them a WHO grade 4. You know, the Wnt activated and a couple of these other subgroups have been shown to actually be potentially curable with appropriate treatment. So I imagine that some of these will start to get their own names, and we will, as we understand them and are able to more reliably identify them, we will further, you know, subcategorize medulloblastomas as the years go on. Okay. So that brings us to our next tumor. Now this one's very pink, which is good. So I always tell my trainees, blue is bad. Blue is bad. This one's pink. So hopefully this one will be good. We see a moderate cellularity with some cytoplasm. Got something that looks like a little bit of a floret here, floret there. Some bizarre looking nuclei in some areas. We have lots of these things, which are eosinophilic granular bodies there. And then we have a little Rosenthal fiber right there. And so these findings, the EGBs and the Rosenthal fibers, are again a reassuring finding, suggesting that this is probably a slow growing tumor. So what is your diagnosis? Very good, pilocytic astrocytoma. Now you remember that pilocytics are most often going to be in the posterior fossa. However, they can be seen in near the hypothalamus, especially in patients who have NF1. So they can be found in other locations, but thankfully the morphology and the histology are the same. And then the most common underlying genetic alteration, although not required for a diagnosis, but the most common genetic alteration, not BRAF, not BRAF. Other options, P53, IDH1, R132H, or KIAA fusion. The answer is actually the KIAA 1549 BRAF fusion. Yeah, so you're close, but it's actually the fusion. Very good. So low-grade tumors, if we can get them completely resected, then there's a potential for a complete cure. All right, let me see how we're doing on time. Okay. So here's another tumor, and this one for me is just what I call instant pattern recognition. So this is one that you just need to be able to, when you see it, you see it. Okay, so this is, here are our vessels. We have lots of blue cells surrounding them. On low power, you might think, oh, is this a small round blue cell tumor? But even at low power, you can see, there's a lot of pink in here. And that pink really kind of seems to be centered around the blood vessels. And so that should hint at the characteristic finding, which I think is probably best depicted in this box. And that is the perivascular pseudo-rosette. So this tumor is also going to be found in the posterior fossa, although can also be found in the hemispheres. And it definitely is in the differential of a medulloblastoma on imaging, but by microscopy, the important thing is that we don't have, there's one mitotic figure there, but for the medulloblastoma, there was a lot of apoptoses, lots of mitoses, so generally high-grade findings, and not a lot of cytoplasm. We have a little bit of cytoplasm here, though. And aside from that one mitotic figure we've seen so far, we're not overwhelmed by the finding of high-grade features. And these are perivascular pseudorosettes, which are the diagnostic finding of ependymoma. Now, ependymomas have undergone a little bit of a transformation in terms of their classification as well, as compared to, say, maybe about 10 years ago. We now define ependymomas according to their location. So supratentorial ependymoma versus posterior fossa ependymoma, which is then subdivided, versus spinal cord ependymoma. And the location is key, but of course, imaging is going to help you with that. Now, the posterior fossa ependymomas they behave differently. So there's posterior fossa A and posterior fossa B, and they are going to have different prognosis. So distinguishing between them is important. So the question here is, which of the following is true about posterior fossa ependymomas? Now, there are a lot of words here, and in the interest of time, we're not going to go too deep into this. Let me just check the results real quick. Okay, so the answer is actually this one, the third one. Posterior fossa A tumors are characterized by loss of H3K27 trimethylation. A tumors have loss of trimethylation. B tumors will not have that loss of trimethylation. And honestly, this is just, I think, a point of memorization, or go look it up every time. I honestly have to look it up because I can forget if it's been a while. Posterior fossa A tumors actually have the worst prognosis over B tumors. This is just a red herring. It's not at all related to ependymomas. And then this one is just the opposite of this. So posterior fossa A's have the worst prognosis, and we can identify them with the H3K27 trimethylation stain by loss of trimethylation. Excellent. Okay, so perivascular pseudorosettes, often located in a ventricle, but sometimes you're only going to have just a little bit of a touching a ventricle next to a ventricle kind of thing, so they don't have to be within it completely. And not a huge number of high-grade features, although again, the presence of high-grade features might cause you to upgrade it, but we won't go too far into that. Okay. This is an EMA stain, and this, I know a lot of people find this super helpful. The textbook will tell you that EMA is going to show dot-like immunoreactivity in ependymomas. I have been burned on this, and so I will share with you a case that was really educating for me, and that is I had an older gentleman who I believe he was in his 60s, maybe 70s, who had a periventricular mass that was circumscribed. And the histology was identical to the picture I just showed you before, perivascular pseudorosettes, not a whole lot of high-grade findings, although it had some mitotic activity. And my EMA looked just like this. And so I signed it out as, I think, something like glioma favor ependymoma. I signed it out as glioma favor ependymoma pending molecular. Well, the molecular came back, and it was a glioblastoma, actually. And so what I learned from that is obviously glioblastomas, we've always been told they got their name glioblastoma multiforme because they can look like anything. In an older patient, even with a periventricular mass, even if the histology is perfect and the EMA is dot-like, I think next time I'm going to back off a little bit on that and defer to molecular before I make a definite diagnosis. So if I had done a GFAP, maybe that would have helped me. So if you're not familiar with this, so in ependymomas, GFAPs will often have a sort of a perivascular condensation. So I don't know how that would have looked in that case, but the key here is that ependymomas tend to be seen in younger patients. And so when you're getting up into the older 6th, 7th, 8th decades, probably shouldn't make that diagnosis. And that includes me. I probably should not have made that diagnosis. So lesson learned. Okay. All right. So that brings us to the next category of tumors. And this category of tumor, I think, is best appreciated first at low power. And so at low power, I can tell that this is brain tissue. I mean, it doesn't look like normal brain tissue, but it has retained some characteristics of brain tissue. I think maybe this is the white matter here, and maybe this is cortex, or maybe that's reversed, but these areas look a little bit different. We have the blood vessels. There may be surface up here, pia, and vasculature there. So this looks like brain, and it hasn't been destroyed by a tumor. But there are too many cells in here, way too many cells in here. Okay, and when we zoom in, we see that those cells are pretty pleomorphic. There's a lot of variability in terms of size and shape and what they look like. This one looks pretty large and dark. I can't tell for every cell, though, whether or not it's a tumor cell or a native cell, but I can say with certainty that there are too many cells in here. All right. And in some areas, you can see that a lot of these atypical cells have abundant cytoplasm. They almost look a little rhabdoid, almost with the eccentric looking nucleus. So this should have you thinking a particular cell type. Now, just looking at that low power, that should have you thinking we're in the realm of diffuse gliomas. And that's because it was involving all of the tissue, but not destroying the tissue. You can still see the background of native brain tissue. It's not like the circumscribed gliomas that are either going to push and or separate the normal brain from the tumor. So this one instead is infiltrative and is showing what looks to be astrocytic lineage to me, because this is not what oligos look like. So what is the diagnosis? Okay, this one is also a bit of a trick because at least according to the WHO, you can't make this diagnosis. You can't make a diagnosis without the molecular, unfortunately. So the diagnosis diffuse astrocytoma is a very specific diagnosis, and I've only actually shown half of the name here. It's diffuse astrocytoma hyphen IDH mutant. So you can't make that diagnosis unless you know the IDH status. Oligo, we can pretty much exclude because it doesn't look like an oligo. And then GBM, it might be because, again, we have to know the molecular. If this comes back as an IDH wild type tumor, then this is most likely a glioblastoma. Based off of the molecular findings. So the answer here is diffuse glioma NOS. And so this is, again, one of those ones that the WHO has kind of limited our ability to make a diagnosis without additional information. Now, which finding would be most consistent with a diagnosis of diffuse astrocytoma, IDH mutant, ATRX mutant, CNS WHO grade 3? Which finding? So this is basically getting at what are the diagnostic criteria for the diffuse astrocytomas, and that's excellent. Perfect. Yes. In the presence of an IDH mutant diffuse astrocytoma that also has ATRX mutation, a grade 3 would be having mitotic activity, but no microvascular proliferation or necrosis. Very good. If you had the MVP or necrosis, you would call it a grade 4 diffuse astrocytoma. Now, this is an example of the IDH1 R132H stain. And in this case, this is very nice because the really large pleomorphic looking cells are the ones that are positive. And so that can really reassure you that, yeah, these are tumor cells. This is one of the only circumstances in which we can look at a slide and distinguish tumor from not tumor cells. Otherwise, as we're looking at those H&Es, sometimes it can be really hard to say which ones are native, normal, which ones are malignant. But with this IDH mutation, we can visualize them. We can also do the same with this ATRX mutation, where you can see ATRX mutation is going to be loss of nuclear staining. So again, our large pleomorphic cells are the ones that are non-reactive, and our native cells retain the staining because they have normal ATRX, and therefore the antibody attaches. All right. So this brings us to the next one, and we'll go to the first area. And again, this is just to illustrate that the sort of low-ish power view for these diffuse gliomas is very helpful at times to, number one, establish the fact that it is in fact a diffuse glioma. Here you can see a gradient, and we're going from pinkish to blue. This pinkish area is going to be the area that's going to be a little bit less involved. It's a little closer to looking like brain. The blue area is going to be almost completely overrun with tumor. But when you can see a gradient like this should be really reassuring that you're dealing with a diffuse glioma. And if we zoom in, we see that there are little small round blue cells. And I believe I had a few other areas. And so this is an area of vascular proliferation. You have those endothelial cells that have just completely overgrown and included the vessels all over the place. And then this is an area with our necrosis. So based upon the histology alone, what is the diagnosis? The answer here is cannot be determined. Again, I didn't put in the full name of it, so I didn't want to give it away, but this is diffuse astrocytoma IDH mutant, CNS WHO grade 4. So the reality is that you cannot tell if you don't have IDH status. You can't distinguish between these two. So if you don't have IDH status, then this should be called diffuse glioma, NOS, and then I would mention that there's vascular proliferation and necrosis. But to be able to give a diagnosis of diffuse astrocytoma, you have to know that it's IDH mutant. To give a diagnosis of glioblastoma, you have to know that it's IDH wild type. Now, for the IDH wild type tumors, if you have a patient, according to the WHO, if you have a patient who is 55 or older, you can use the IDH1 R132 antibody alone. And if it is negative, you can assume that is going to be an IDH negative tumor. So you do not have to do molecular testing on all of these to be able to come to that conclusion if the patient is 55 or older. If they're 55 or older and the IDH1 R132H is negative, and they have, this necrosis and vascular proliferation, the high-grade features, then you can call it a glioblastoma, IDH wild type, CNS WHO grade 4. However, if this were an IDH mutant tumor, this instead would be diffuse astrocytoma, CNS WHO grade, IDH mutant, CNS WHO grade 4. Okay. So what molecular alteration would confirm a diagnosis of glioblastoma? So let's say that you are able to do the molecular testing. Aside from IDH, what other alteration would confirm a diagnosis of glioblastoma? Okay. So the answer is actually more than one of the above. So in a patient who has a tumor that looks like this, who does not have an IDH mutation. So let's go back to our more low-grade looking astrocytic diffuse glioma 2 or 3 slides ago. In that tumor, if it is IDH wild type, yet it didn't really have microvascular proliferation, it didn't have necrosis, it didn't have the high-grade features that we think of as going along with a grade 4. The presence of either a TERT promoter mutation, EGFR gene amplification, or gain of chromosome 7 and loss of chromosome 10, any one of those three in an IDH wild type tumor is enough to call it a glioblastoma, even if it does not have the high-grade features that we tend to associate that with. The reason for that is because sometimes these tumors are, biopsied and or resected before they really manifest as being high grade with all those high grade features. But these behave in such a way that they are anticipated to go from, looking lower grade to frank GBM in a matter of weeks to months. And so these are treated much more aggressively. So if they have any of those three molecular findings in an IDH wild type diffuse astrocytoma, they are considered to be glioblastoma, even though what we think of as the histologic findings of GBM are not present. Okay, so that's one of the caveats here is that in the IDH wild type tumors, the histology kind of is less important than the molecular findings. And so this is one of those circumstances where having the molecular is of importance. Okay. Let's have a look at this one. So here's another, let me zoom out again. Here's another one of those low power, okay, I see what looks like brain tissue, but it's too cellular. And then when we look here, we have that oh so classic fried egg with the halo around the relatively monotonous rounded nuclei, monotonous looking nuclei. But then here's an area here where we don't have the halos, but we still have the relatively monotonous round looking nuclei. So diagnosis, we have 2 votes for oligo, and most likely, yes, this is an oligo. What is the most likely diagnosis is an oligo. Now, the reason that we tend to jump to that is because that the finding of this perinuclear halo, this tends to be more associated with oligodendrogliomas. Now, this is an artifact of delayed formalin fixation, which is why I highlighted this area on the edge. The areas on the edge or in very small biopsies that get put in formalin very quickly, you may not have halos at all. They may not be present. When halos are present, they tend to be more central because it took longer for the formalin to penetrate in there. So delayed formalin fixation causes this. So don't panic if you don't see the halos. It doesn't mean it's not an oligo. It may just mean that it was fixed fairly well and fairly quickly. The important note is that they're still monotonous, round-looking cells with not a whole lot of cytoplasm. They didn't have those big cytoplasmic bellies like the astrocytic cells did. And so this is a clue that this is probably an oligo. Now, the one mimicker that's here is the PLNTY, plenty. Plenty is one of the tumors that is in the category of oligo-like tumors. because they look a lot like oligos, and microscopically, this absolutely could be plenty. But if you had had time to review the slides, you would notice that there's really not calcifications, which is a prominent feature of PLNTY. On top of that, they tend to be of the younger patients. They absolutely have been described in older patients, though. But in a tumor that looks like this, pretty homogeneously the same, not really any calcifications, I would make plenty much lower on my differential. It's not going to be likely to be that with this appearance. And which of these molecular features is not seen in oligos? Not seen. So that's the key, not seen. you can't read too quickly. So not seen. So a 1p19q codeletion is seen in oligos, as is IDH mutation. What is not seen is ATRX mutation. Those do not coexist, the 1p19q codeletion and ATRX. So very good. All right. In the interest of time, I'm not going to spend too much time on this one. This is a posterior fossa mass. Often it's going to have a little bit of a dural connection, but not always. And let's see, I may have clicked on that too quickly. I apologize. So key features here is that we have lots of blood vessels, large, medium, and small capillaries. And sometimes we're going to get lucky and get a little bit of clear cells, sort of vacuolated cells in the background. And so that gives us a diagnosis, most likely hemangioblastoma. However, it's very important to remember that these are seen in a germline mutation syndrome that also has renal cell carcinomas, and that is VHL, very good, chromosome 3p. And so it absolutely could be metastatic renal cell carcinoma. We would definitely do stains. Inhibin will be positive in the hemangioblastoma, and then it will be negative for some of the RCC markers, CD10, et cetera. So hemangioblastoma is a common one that we see. This one. Okay, this brings us to our last category of tumors. Now, this is from the pituitary gland, the sella. I know not everybody, at least from what I'm told, not everybody who's a neuropathologist receives the pituitary gland tumors. We do at my institution, but in some places they go to what's called an endocrine specialty. But since I see a lot of these, and I've actually spent a lot of time on a couple of these this week, I thought I would include them in here and show you the algorithm that I've created that you may find helpful. I use it on the vast majority of my cases. So pituitary adenomas, pituitary adenomas can look like anything. They can mimic just about any kind of neoplasm. And I will urge you to be cautious because I have seen several cases of metastatic carcinoma to the pituitary gland that on first glance looked like a pituitary adenoma with mitotic activity. So anytime I see mitotic activity in a pituitary adenoma, they certainly can have some, but I'm going to be cautious and make sure that the patient doesn't have breast cancer, make sure that there's nothing else going on in this patient, and also do all of the transcription factors, et cetera, that are related to pituitary adenohypophysis, because I have been burned on that before. So these really can look like anything. And if you read the WHO on these, you'll find that there are some morphologies that are kind of suggestive of certain of the subtypes. I may make a guess according to what I'm seeing on histology, but I always ultimately rely on the hormone status and the transcription factors. So when you have one that has a little bit of a trabecular look to it, that one is, trabecular is a pattern that is kind of associated with gonadotroph adenomas. And so this one, to me, I would be suspecting this is probably gonadotroph adenoma. Has a little bit of a trabecular look right here. The next one, here's another one that I will show you. This one again. This one doesn't look so trabecular. It's almost more like a small cell. Some of them almost look a little maybe rhabdoid or plasmacytoid. So gonadotroph is not necessarily the top in my differential. I can tell you actually, this one is a densely granulated sparsely granulated somatotroph adenoma. This one here was associated with a gangliocytoma. Now I saw one of these last week. And I want to put this here because it is not infrequent for gangliocytomas to arise in pituitary adenomas. It's a known entity. It happens, but every time I get one, I panic for a minute and I think, oh my gosh, we're not in the pituitary gland. What is going on? And then I have to calm down, back up, zoom out, and remember that, oh yeah, okay, there is an adenoma here. It's present. There just happens to be another thing. And so it's just a classic gangliocytoma. If you were to do your usual, neuronal stains, these would be positive. And so in these cases, I give the subtype of the adenoma and then also mention that there's a concurrent gangliocytoma present. And then the last one I'll show you before I take you to my algorithm is this one. There are a subtype of adenomas that can be treated clinically to some degree. And those are the ones that are prolactin secreting. So the prolactin secreting adenomas, they're by definition, they're going to have elevated serum prolactin levels. Now, when a patient is identified clinically as having an adenoma with secreting prolactin, often they're going to be placed on a medication, like cabergoline. And for many patients, that can actually help control their prolactin levels for a pretty good period of time before eventually, at some point, they usually are going to need to be resected. But that treatment, the cabergoline treatment or their similar medications, often causes a change in the pituitary adenoma that looks a lot like this. Now, I can't be certain, this is not my case. I can't be certain that this patient was treated with this, but this is an awful lot what it looks like when you have a patient with a prolactin secreting tumor who's been treated. It's this sclerosis, and it can really make it look bizarre, and it can make it difficult for you to figure out which type of lactotroph adenoma it is. So just keep that in mind. If they've been treated with something like cabergoline, it can make it look bizarre, and that may explain if you're having trouble figuring out which one it is. It can explain how do we differentiate between adenoma versus hyperplasia? I'm so glad you asked that. I literally had one of these last 2 weeks ago. It's the first one I've ever seen, and it was incredible. The difference is in the pattern of staining of the hormones. So in an adenoma, now I'm assuming we're talking about an adenoma that is making one hormone type. So let's take a lactotroph adenoma. I'm only making prolactin. All of these cells are going to be positive for prolactin and the transcription factor for prolactin, which I believe is PIT1. I have to look at it every time. So all of the cells. Now you may occasionally see that when they've resected it, you've got little spots that also have they're the normal pituitary gland. And in those areas, you're going to see a mixture of all the hormones. And so you generally will see an area producing only a single hormone or no hormone at all, and an area that has a mixture of many hormones. The area with the mixture, that is going to be adenohypophysis, just normal gland. The other area is your adenoma, and that you would type according to what hormone and transcription factors are there. Hyperplasia can be very challenging. However, in general, you're still going to have a relatively diffuse staining of most hormones. Now, the one that I saw last week, which is actually one of the more common ones, is thyrotroph hyperplasia. So that's the thyroid, TSH, basically cells producing TSH. And that was in response to primary hypothyroidism. The patient had hypothyroidism. So that's a common clinical scenario. In that case, the TSH was wildly positive, which it's never. TSH is never positive. So TSH was wildly positive. And then, but all of the rest of the hormones were also kind of mixed throughout it. And so because I didn't have a definite distinct area that showed single hormone type and then mixed hormone types, that these are separate, that was hyperplasia. You can also use reticulin, but reticulin is going to be abnormal in hyperplasia as well. It's in an adenoma, you may have learned that you lose the reticulin, and that's an easy way to help recognize it. You can't use that 100% for hyperplasia, although you may be able to see areas of just enlarged spaces rather than completely destroyed. So that might kind of help you in one direction or another. But excellent question. Excellent question. Okay, so with that, my last slide, and I'm going to give a massive disclaimer on this. This is not a complete list of the pit nuts, so please refer to the WHO. But this algorithm I've created according to the WHO of endocrine tumors, and this helps me with 90% of my cases when I'm trying to sort them through and figure them out. The reason we have to distinguish between these is because, okay, I'll I'll look at that message in just a second and I'll answer that question. The reason that we sort between these is because some of these are clinically aggressive. Not all of them. Actually, the vast majority of these adenomas are benign. They're not going to be aggressive, but like the Crook cell adenoma, the acidophil stem cell adenoma, they are going to behave more aggressively. So the clinicians want to know when it is one of those. So I've put up here pit adenomas slash neuroendocrine tumors, and I'll just say I still call them adenomas in all of these. And when I speak about them, I call them adenomas, but just know that when it comes to my final reports, I follow the WHO, which says to call them adenoma slash neuroendocrine tumor. But that's a mouthful. So the three transcription factors are here, PIT1, SF1, TPIT. If all three of those are negative and all 6 hormones are negative, it is a null cell adenoma. These are very rare. And then depending upon, which of these are positive, you follow down the pathway. So the stains that I do regularly on all pituitary adenomas, it's a lot, but I find it necessary, is the 6 hormones, the 3 transcription factors, Ki67 and CK818, plus or minus synaptophysin, reticulin, just kind of depending upon the circumstance. And then that sort of, I walk through the process here. Now, this is a gross oversimplification because this does not include things like the lactosomatotrope adenoma or the dual adenomas, where you can have 2 completely different types in a single adenoma. And so if you're seeing something that doesn't fit into this algorithm, by all means, go back to the WHO to look at it. So the question, what if more than one stain's positive? You might be dealing with a dual adenoma, or, for example, prolactin, the lactotropes, can have growth hormone as well. So if they have a shared transcription factor, it may be that it's just expressing hormone from the influence of the transcription factor. However, if it's like prolactin and ACTH, those have completely different transcription factors, and so that's very likely going to be a dual adenoma. And so that would be, again, one of those where it's not going to fit this algorithm. You're going to have to step back a second and think, okay, is this an overlap? Is this a hyperplasia? Is this something else? So this will not encompass all of your adenomas, but for my cases, it captures about 90% of them. Okay, so the change that happens if you take treatment for lactotroph adenomas. Yes, let me see if I can go back. Here we go. So when they've had treatment, oral treatment, it's typically going to be a sclerosis like this. And the reason that this becomes difficult, and honestly, because I'm struggling with this right now on a case I have on my desk, is so all of the sclerosis means that I have very few cells. And in my case, my piece of tissue is like 2 millimeters, so I don't have a lot to deal with either. And half of it is the sclerosis. So we're looking, but it is diffusely prolactin positive and PIT1 positive. So it's in this family of lactotroph adenomas. It's in here somewhere. To distinguish between these, you have to be looking at your, and again, it's more complicated than what I have on here, but there may be fibrous bodies that I would see on the CK818. There may be, if it was an acidophil stem cell adenoma, you may be looking for clear cells. And I kind of have all the features for all 3 of these. And so I'm not really sure what to call this. But one other thing that I have included in here is ER, estrogen receptor, tends to be positive in the sparsely granulated lactotroph adenoma. And I do have some faint ER staining. So I think in that case, what I'm going to do is I'm going to say lactotroph adenoma see comment, and just say that, there's overlapping features, but I favor this is probably sparsely granulated and that they'll need to follow up. And honestly, that's just the reality of pathology. We can't always come up with a definite diagnosis, and it's so frustrating. But, we just do the best we can with what we have. So, all right. Are there any other questions? And I want to thank you so much for interacting and for asking the questions that you did. I think that makes it so much more rich and meaningful. But if there aren't any other questions, I will toss this back over to Dr. Hassel.
Well, Dr. Peterson, this has been a wonderful session. I feel much more comfortable if I were to have to sub in for you and cover frozen stuff on an occasion now and then with your guidance there. And I think you've covered a lot of ground that's very useful. Certainly, when the video goes up, there may be additional questions. We'll try to steer those your way as well. But if anybody has any... Final questions?
I think Dr. Seng, I don't know if I'm saying that right. I'm so sorry. Song?
Yes, same.
Seng.
Uh,
Okay.
thank you very much, Dr. Peterson. So I have one question. Do you grade pituitary adenoma in your
Do I
practice?
grade? No. I do not. No. I don't believe the WHO does as well. I could be wrong on that, but I don't believe that the WHO gives a grade. I do give the CAP synoptic, CAP creates the College of American Pathologists creates like a synoptic summary, but I don't. But I'm gonna actually go double check that today and make sure I'm doing it right.
Thank
Thank you
you.
for that question.
Yep, thank you very much for your presentation. Thank you.
Thank you again, everyone. And just for information's sake, to look forward to next month, we'll be going back out to the surface of the body, and our one of our prior guests, Dr. Thuy Pham, dermatopathologist, is going to be sharing some of her cases and further approach to skin pathology with us at that time. JoElle, thank you so much for this wonderful presentation today, and I know we'll be seeing a lot of interest in this going forward, and hope that everyone will be able to apply it in their practice. So with that, have a good day, everyone. Thank you for joining us.
Thank you. Dr. Hossel, there's a question in the chat about how do they find out more information about future sessions?
Oh yeah, so we do post all of our sessions on the website Patholist, which is posts all sorts of online activities going on in pathology. That's patholist.com, and I also put it on the Facebook group and in my personal Facebook page. So that's usually the place where the notice comes out, and usually about a week in advance. We'll also post, of course, the link to these slides if you have lost that with the video later on. Thanks, everyone.